All right. Welcome, everybody. I'm Richard Hain. I'm a surgical oncologist here at UH, and very excited to introduce today's speaker. I think we have a wonderful talk. Just for some housekeeping notes, real quick, this webinar is being recorded. It'll be available to review from the Research and Education Institute website in the coming days or weeks. And so you'll have a chance to view that. Please make sure your microphones are muted throughout the presentation. If you need technical assistance, Nicole Bollinger and Abigail Zona are on the call. You can send them messages, chat messages. And if you want to ask questions, feel free to type them into the chat. At the end of the talk, we'll do some questions and answers. Everyone can see your questions, but you do have the option to submit to Nicole or Abigail anonymous, or to me anonymously, and we can ask that way. So with that, I'm very excited and honored to introduce Lilliam Ambroggio, recently promoted to Professor of Pediatrics. She's the Director of Research in the section of Emergency Medicine at University of Colorado and Children's Hospital in Colorado. She is a implementation science expert. She's got multiple federally funded projects, mostly focused on children with infectious and respiratory diseases, looking at methods for improving diagnostic accuracy and implementation of those methods across a variety of clinical scenarios. She's published well over 120 papers and is an expert at mentorship and developing trainees and junior faculty, and has been very influential in my grants and development thus far, which I appreciate. So today we have a presentation called From Evidence to Pathways, Health Services Research in Pediatric Pneumonia Management. And I'm very, very excited. So Lilliam, the floor is yours.
Thank you. And thank you so much for the kind introduction and for inviting me to give this talk. Let me go ahead and share my slides. All right, hopefully everyone's seen the slideshow. So I am going to talk a lot about pediatric pneumonia today. That is my topic of interest. And please ask questions. Hopefully I will answer all of them by the end of the talk. So we have some learning objectives. So first I want to talk a little bit about the burden of pneumonia worldwide, and then also I'll speak a little bit about the burden within the United States. So as depicted here, death from pneumonia affects the elderly population and very young children. The one thing about pneumonia that we need to remember is that most causes of pneumonia, bacterial causes of pneumonia, are preventable through vaccines, and most causes of viral pneumonia are preventable through good hygiene. And it is a very treatable illness. Since the 1990s and the advent of pneumococcal vaccine and the Hib vaccine, we have seen this very significant decrease, which you can see in the chart, in pediatric mortality due to pneumonia. However, pneumonia remains the #1 killer of children under 5 years worldwide. My talk is really focused on the younger age group, so 0 to 18 years of age. So pneumonia was first documented as winter fever by Hippocrates in around 460 BC, and this is a painting of Hippocrates evaluating a pediatric patient. Not really sure if they had pneumonia or not, but it's a nice picture. Over 2,400 years later, pneumonia is still the #1 killer of children under 5 years of age worldwide, and an estimated amount of 740,000 children under 5 die annually. However, we need to think about mortality from pneumonia based on location. And unfortunately, most of the mortality, the highest rates of mortality, which would be the darker blue, darker green colors, you can see are in sub-Saharan Africa and parts of South America. In high income or high middle income countries like the United States or many countries in Europe, there's a really low rate of mortality due to pneumonia. However, there's still a substantial morbidity due to pneumonia, and we'll get to that in a second. So why is pneumonia so challenging? Well, pneumonia diagnosis in children is based off a few factors: physical exam findings, usually a chest radiograph, sometimes culture to try to identify a causative agent, a causative typical bacteria, and then sometimes also PCR for viral and atypical bacteria. There are also many biomarkers that we can look at and people have looked at. However, their influence or impact on diagnosing pneumonia is still somewhat controversial. So if we go into physical exam findings, here's a study that my colleague and I did many, many years ago, where we recruited physicians to do 128 paired physical exam findings on children who presented to the emergency department with a clinical diagnosis of pneumonia. And we asked 2 physicians, so they were all either a pediatric emergency medicine trained physician or a PEM fellow. And we asked them to do a physical exam on the same patient, no more than 20 minutes apart, and without any interventions done in between, with the idea that the patient would present very similarly for both providers. And what we found, as you can see, the little blue triangles are the raw agreements, and then the black is the kappa agreement or the inter-rater reliability. And what we found is of all of these very common physical exam findings that are usually recorded for pneumonia, only 2 had high or moderate inter-rater reliability, meaning that only wheezing and retractions had high enough reliability above chance that 2 providers agreed that the patient was presenting with wheezing or retractions. Every other exam finding, even things that we thought would be very objective, like saying a patient was tachypnic, had either low or no better than chance when providers were looking at these findings. So physical exam findings alone are very dependent on which provider is diagnosing the patient with pneumonia. So how about chest x-rays? So chest x-rays are very commonly done in patients with pneumonia. In one study, about 85% of children who present to the emergency department get a chest x-ray to rule in or rule out pneumonia. In this study, we asked 5 different pediatric radiologists to look at chest x-rays from children who were clinically diagnosed with pneumonia and asked them to record without clinical history and with clinical history what findings they found on the chest x-ray. So you can see again that only 2 findings really have somewhat high to moderate inter-rater reliability, where again, 2 pediatric radiologists agreed that this was a finding on the x-ray. So any infiltrate is sort of moderate and honestly is not better than chance, but alveolar infiltrate or consolidations had really high inter-rater reliability, and it didn't really matter whether they had clinical history or not. Every other finding, including pleural effusion, which was kind of surprising, had either moderate or poor inter-rater reliability. So findings on chest x-rays are are variable and very dependent on who is reading the chest x-ray. So what about culture? So in a study of 7,509 children who were hospitalized with pneumonia, 34% had a blood culture. And of those who had a blood culture, most of the bacteria that was grown was Streptococcus pneumonia. 7.7% with Staph aureus and 4.6% with Hib. And in this bar chart, what you can see is that among those who had severe or complicated pneumonia, the proportion that had a positive blood culture was much higher, but it still was only around 4 to 5%. In those kids who had non-severe and non-complicated pneumonia, the proportion who had a positive blood culture was much less, and about 2%. And again, of that 2%, most of them were strep pneumo, which is usually covered by amoxicillin or ampicillin, which is currently the recommended first-line antibiotic therapy. So blood culture is not very helpful in pathogen identification. So what about PCR for viral and atypical bacteria? So most institutions, but not all, have some sort of respiratory pathogen panel, which includes a variety of viruses that are usually listed here, and now includes SARS-CoV-2 since the pandemic, and usually includes 2 atypical bacteria. The one that is most common, and we'll talk more about at the end of the talk, is Mycoplasma pneumonia. PCRs are very sensitive and very specific. So this particular PCR, which is what we use at Colorado, is the BioFire film array, and it has a 97% sensitivity and a 99% specificity. The issue here is And as I will show in the next couple slides, even though a patient can present and have a virus detected, it doesn't necessarily rule out that they don't have an underlying bacteria. And as I just showed with culture, there's really no good way of identifying bacteria in a patient, in a pediatric patient. So this is very different than adult patients who have a much higher rate of bacteremia than in children who have non-complicated or non-severe pneumonia. So we can reliably identify viruses, reliably identify atypical bacteria, but cannot reliably identify typical bacteria. So etiology can be very difficult to detect. This was a global study titled PERCH that was led by a team at Johns Hopkins, and they found that in kids with severe pneumonia, this was based on the World Health Organization, but essentially kids who were hospitalized with pneumonia and had very fast breathing, in children who were less than 5 across 7 different countries, which included Bangladesh, Gambia, Kenya, Mali, South Africa, Thailand, and Zambia, that most of the causes of pneumonia were viruses. So 61% of all kids with severe pneumonia who were admitted for their pneumonia were caused by viruses, with no bacteria being detected. And 31% of those were respiratory syncytial virus. 27% were due to bacteria, and then much less commonly, and these are in non-HIV children, non-HIV positive children, much less commonly were fungi or tuberculosis. And I think that what's really important from this study is that they identify that even in severe cases of pneumonia in children that required hospitalization to the intensive care unit, that most of these were due to viruses, not due to bacteria. In a study in the US, they found that pneumonia is the third most prevalent reason for hospitalization, and that is the blue bar graph to the left, in kids who do not have any medical complexity. In kids who do have chronic complexities, it is the fourth most common reason for hospitalization. And what's interesting about this is that the red line on both graphs shows you the cost in millions of the disease. So even though it is not the most costly reason for hospitalization, we are still talking about 550 million per year in treating children with pneumonia in kids that don't have medical complexity, compared to around 700 million in kids who do have some sort of comorbid chronic complexity. And in the US, there's about 3,000 deaths due to pneumonia each year in children. So in another study in the US that again was looking at etiology and trying to identify what are the most prevalent reasons, bacterial or viral reasons for pneumonia, this study called EPIC, the etiology of pneumonia in the community, was across 3 different hospitals. And they found that, again, RSV is the most common reason for, or the most commonly detected reason for pneumonia. And the way that this chart is set up is the darker part of the bar are singly detected infections. So the kid only had RSV detected. And the lighter color of the bar is a co-infection. So for RSV, about 17% of kids had only RSV detected as their cause for pneumonia. And in about another 10% of kids or so, there was a co-detection of RSV. What I think is really interesting here, again, is that the first 4 large reasons or causes of pneumonia are all viral. So RSV, human rhinovirus, human metapneumovirus, adenovirus are all the primary reasons for pneumonia. Mycoplasma pneumonia is then the fifth most prevalent reason for pneumonia, but also the first most commonly detected bacterial reason for pneumonia, with strep pneumo being much farther down the line. I think another really important part of this study is that even though they were using both clinically available and also research available molecular microbiological tests, so they did blood cultures on everybody, only 81% of children with radiographic pneumonia had a pathogen identified, meaning that there's 19% of kids that we still don't know what's causing their pneumonia. This study looked at 524,000 children from 32 hospitals in 2010. And they found that 4 different conditions accounted for 10% of all days of therapy, even though These were less than 1% of all the clinical conditions for children to be hospitalized. What they found and what this graph shows is that each of those circles is one institution or one hospital. And the size of the circle is the number of discharges with a given diagnosis. So in this case, it's for number of discharges with pneumonia. And so in this case, what you can see is that among the different hospitals, most hospitals prescribe antibiotics about maybe 15 to 20% of the time, with some hospitals prescribing 50 to 80% of the times for children with pneumonia. So why do we care, right? Antibiotics are fine. Usually we use narrow spectrum antibiotics. Well, antibiotics are given empirically, which can lead to overuse and increase the prevalence of drug-resistant organisms in the community. From an individual perspective, antibiotics are also responsible for 1 out of 5 emergency department visits for adverse drug events. Antibiotics are the most common cause of emergency department visits for adverse drug events in children under 18 years of age. So this is really important to consider. Antibiotics are not without consequence, even narrow spectrum antibiotics. And there have been many, many papers showing that antibiotics early in life, so in kids under 5, can increase the risk of asthma and other chronic conditions and change their microbiota, their underlying microbiota, which might increase the risk for other respiratory infections or more severe respiratory infections in the future. So giving antibiotics empirically when most kids from these etiology studies have been shown to be viral as a cause may not be the best practice. So the first thing that we did, and I did this when I was a fellow, so many years ago now, prior to 2011, there was no United States guideline for appropriate antibiotic therapy for pneumonia. So the first thing we did was actually look at what antibiotic prescribing was going on among children's hospitals. So this graph shows antibiotic prescribing practices for 33 children's hospitals across the US. So the children's hospitals are randomly assigned in number, which is down on the x-axis, and then the proportion of the antibiotic prescribed is on the y-axis. And as you can see, immunopenicillins, which is in the dark purple, were rarely prescribed with the exception of hospital number 1. Whereas cephalosporins, which is a much broader spectrum antibiotic, was more commonly prescribed, but still in a variable fashion across the different hospitals. We also looked to make sure that the different populations in each of these 33 hospitals was similar. So there's no reason to believe that children who went to hospital number 33 were more severe or somehow different than children who went to hospital number 1. In fact, this was a very common homogeneous for pneumonia group of children across all 33 hospitals. So before I get to the next step of sort of, well, what do we do with all this information? I also want to emphasize that even though we as investigators, as providers, sometimes think of our own siloed clinical practice, so whether that is a clinic, whether that is the emergency department, whether that's the ICU or the inpatient, the general inpatient ward, a child goes through all sorts of settings. And so we need to take a more holistic view regarding where these treatment decision points are. So in this very basic diagram, what I'm trying to show is children with pneumonia most commonly will go to a primary care practice or family care practice first as their first point of diagnosis of pneumonia. And this is the first point of that decision for the provider of, do I need to give this kid antibiotics? Sometimes kids do not go to the primary care practice or go to that primary care practice and then end up in the emergency department, which is again, another point in which we need to decide, do we give this kid antibiotics? If they came in, and about 20% of all kids with pneumonia do come into the emergency department on antibiotics, the question then becomes, do we need to change their antibiotics? Do we need to broaden their antibiotics? Do we need to continue them on their antibiotic? Or do we need to remove them from antibiotic? And then a smaller percent of those, so about 30% of kids who come into the ED will then be hospitalized with pneumonia. And then again, there's another decision point. Do we continue what happened in the emergency department? Do we change the antibiotic? Do we remove the antibiotic? Do we switch from IV to PO? All of those decision points are important decision points and have different factors that are associated with them. And at any point in time, right, these children could be discharged and sent home. And then there's a whole another set of literature about what do we do at home and what is the right outcome measure when kids are sent home. So the first thing we did is when there was a guideline that came out in 2011 that was looking at, that was from the Pediatric Infectious Disease Society and Infectious Disease Society of America. And this is what they recommended for patients that were well enough to be treated as outpatients. So for those who were infant or preschool age, they recommended no antibiotics because viral pathogens are most prevalent. They also recommended amoxicillin as first-line therapy if previously healthy and immunized. And some of this has changed since 2011 because of this idea that strep pneumo causes more mortality than any other bacterial cause of pneumonia. And this is the most prevalent cause of bacterial pneumonia. Typical, I should say, bacterial cause of pneumonia. And so it was thought that let's do the most narrow spectrum antibiotic that we can that still covers the most prevalent bacteria that causes the most mortality. In school age kids, again, amoxicillin was recommended as first line therapy. And then there was a very weak recommendation for giving azithromycin for children who were older, who may have, quote, findings compatible with CAP caused by atypical pathogens. Now, what's important here, and the reason that it's a weak recommendation, is that there are no findings compatible with pneumonia, at least that have not been published. There has been one paper with a small n that showed that maybe there's a couple of findings, but that has not been validated. And there's a myth that wheezing present in a child with pneumonia is more likely correlated with atypical bacteria or mycoplasma pneumonia, and that has been shown to not be true in multiple studies. So for inpatients, it's a similar line of thought where ampicillin, or again, if they tolerate oral antibiotics, amoxicillin is the first line recommended antibiotic, and this is a strong recommendation. For those that are not immunized or in regions with high levels of penicillin, resistant pneumococcal strains, then there was a weak recommendation to broaden spectrum to third generation cephalosporins. The secondary agents, again, atypical bacteria was recommended to be treated with macrolide. However, this is a weak recommendation because there's not enough studies to support that macrolides actually treat the atypical bacteria in most children. And again, I will talk about that in a little bit later. So our first line is we thought, okay, it takes 17 years to passively implement guidelines into practice. Therefore, we decided at one of our hospitals, we were going to use quality improvement science to implement the treatment recommendations from the guideline in our emergency department and then also our inpatient ward. So along the x-axis, for those who are unfamiliar with run charts, is the week of service with the number of patients that were seen that week. And then on the y-axis is the proportion of patients who received appropriate first-line antibiotics. And the reason that we said first-line antibiotics is that we did consider if a patient had a documented penicillin allergy and received the appropriate first-line antibiotics in regards to that. Otherwise, it was either amoxicillin or ampicillin. Something to note about this graph is it looks like 0% of children during baseline did not receive any antibiotics, and that's not true. They were receiving antibiotics, but they were receiving third generation cephalosporins because that was what our local guideline had recommended prior to the national guideline coming out. So what you can see is that in mid-October, we implemented our first training session. So hopefully you can see my pointer here. And you can see that we did some education, we did some EMR changes, and over time, we were able to increase appropriate first-line antibiotic therapies above the 80% goal, and we were able to sustain it for many months after that. Similarly, when we look at our inpatients, again, this is a second point of decision. So patients who were admitted the inpatient team can decide, do we continue the antibiotic that was given in the ED, or do we change the antibiotic to a narrow spectrum antibiotic? So the way that we looked at this was, did the inpatient team, regardless of what the ED team did the inpatient team prescribe appropriate first-line antibiotic therapy? Again, we did some education, we did some EMR changes, and you can see that we improved overall first-line antibiotic prescribing. So this is all well and good. This is a hospital system. It's a lot easier, I think, to change and do improvement science in a hospital. So the next part was, well, we really need to focus on our community practices. So in this study, we worked with 5 primary care practices, which included 10 different sites and over 42 providers. And what's interesting about this one as well is they had many different electronic medical record systems. So whereas our hospital, for the first 2 graphs, we're using Epic, this hospital, or not hospitals, these community practices had 3 different EMR systems. So when we made EMR changes, it was a lot harder to do it across different systems than it was to do it at our own hospital. But it was part of the learning process. So we used a step wedge design to implement the guidelines in a sequential fashion to each of the practices over a couple of years, as shown by the color bars along the bottom. Each color represents a different intervention, and the x-axis is the month in which the child was diagnosed with CAP and visited the practice, and the y-axis again is the proportion of children who received guideline-recommended antibiotics. So our median prescribing of guideline antibiotics was around 30% to start. That was our baseline, which is represented by that red center line. And then through these different interventions, which all have different colors to match the step wedge design, we reached our goal. We didn't quite reach our goal, sorry. We achieved a 70% success rate, not the 80% that we were hoping to reach, which is the green dotted line. Our failure to reach our goal is due to many reasons, many of which come back to the fundamental issue that we do not know what pathogen is causing infection, and therefore it is challenging to target antibiotic appropriately. We had a lot of questions about, well, this child came in with acute otitis media, so we're treating that, but then they came back with pneumonia, so we changed antibiotics because obviously the antibiotics weren't working. But those are 2 different infections, but they're related. And so there was a lot of questions about what do we do in these cases? So there's still a lot of work that we need to do in the community setting to standardize antibiotic therapy and to improve our diagnostics to detect pathogens. So how are we doing now? So we did a study recently, a couple years ago, looking 10 years out from the guideline, and 10 years is a long time for guideline not to be updated. And I know that they are working on updating this guideline, but 10 years from the guideline, we do see this improvement of narrow spectrum antibiotic prescribing. And this study was done across 40-some different children's hospitals. And you can see this line shows when the original guideline came out in 2011. This is the pandemic. And what you can see is among those patients who were admitted with pneumonia, there's this very nice increase proportion of children who are receiving narrow spectrum antibiotics or immunopenicillins. And then among kids who are discharged from the ED, again, you see less of a steep increase, but still an increase. Now, something that I want to point out is this little bump here around the pandemic that we're going to get back to. But you see this little decrease among the ED and inpatient sides where we just slightly decrease immunopenicillin prescribing. And I think some of that is due to the fact that we didn't see a lot of pneumonia, which I will show you in a second. And then 2, people, I think what I noticed and what papers have shown is that we kind of forget how we practice when there's a new virus out there and when there's something unknown out there. So we tend to order more diagnostic tests. We tend to prescribe broader because we're just trying to cover everything that's happening. So this is from the same study, but it's looking at very specific antibiotics. So again, you have your amoxicillin and your ampicillin. So the amoxicillin is this blue line, and you can see it increases very nicely. Same with the ampicillin from 2009. It's increasing very, very nicely. A little dip again around the pandemic. The none category is very interesting in that it kind of stabilizes. It went down a little bit, but then now it's creeping up again. Now remember, if we look at the proportions, 60% of kids that were hospitalized with pneumonia, both from the EPIC study and the PERCH study, found a viral cause to their pneumonia. And yet only about 25 to 30% of kids are actually not getting antibiotics for their pneumonia. Most kids, up to about 45% or 50%, actually you have to add these 2, so it's about 80% of kids are getting some sort of antibiotic for pneumonia. So cephalosporins, again, are going down. That's wonderful. That's exactly what we would want to see. And then macrolides are really funny. So macrolides started around 30% or so, went up, and then now we're going down again in 2021. And we'll talk about this dip in 2021 in a second. And macrolides or Mycoplasma pneumonia is detected in about 20% of cases of kids with pneumonia, and mostly in older age kids. So this graph is all children, not divided by age group. So what happened with the pandemic? Well, here's what happened with the pandemic, right? These are just number of hospital encounters of children with pneumonia across 47 pediatric hospitals. And so what you can see from here is it's pretty stable, maybe going down a little bit, goes up a little bit, and then here's the pandemic, and it just dropped precipitously. It's going up again now that the pandemic has over, and I don't have the data for the last couple of years, but I can tell you it's kind of coming back up to semi-normal levels. It's around 5,000 to 6,000 encounters per year now. So what happened during the pandemic? Well, we had non-pharmaceutical interventions. We had a lot of competing viruses like SARS-CoV-2, which cause pneumonia, but not as much as other viruses that usually cause pneumonia. So what do I mean by non-pharmaceutical interventions? I mean, we all lived through it, so I won't spend too much time on here, but right, we did things that in general protect us from all viruses and most circulating bacteria that cause pneumonia. So things like physical distancing, things like strict hand hygiene, respiratory etiquette, all these things help stop the spread of typical viruses and typical bacteria that cause pneumonia. So now let's talk about how these viruses, and specifically how Mycoplasma pneumonia as an atypical bacteria, how it has had this delayed reemergence. So again, we had this huge drop, and then we had a triple pandemic when we had RSV, we had enterovirus D68 come, and then we also still had a lot of circulating SARS-CoV-2. Well, for Mycoplasma, which was a commonly detected bacterial cause of pneumonia, we observed this delayed reemergence compared to other pathogens in many countries. So this is a global study, which my site, which I contribute to through my site. And so you'll see we're one of the sites in the USA, our dark green line. But what you'll see is in 2022, 2023, so well after the pandemic, you see almost no mycoplasma. And remember, before the pandemic, it was a pretty common cause. It was about 20 to 30%, depending on the age group. And then all of a sudden, we're seeing this reemergence, not just in the US, which is pretty high, but everywhere. So this is, I think this one is Belgium. We're seeing it in, just across all countries. And there's newer data that has come out that has now shown that we had an outbreak in the last fall of 2024 into the winter of 2025, and it came back hard. In one study that I looked at, we had about a 35% prevalence of Mycoplasma pneumonia in kids with pneumonia. So some of the challenges of Mycoplasma pneumonia. So the first part of the talk, I feel like we did really well. We increased narrow spectrum antibiotics. That's all well and good. So now we're moving on to another challenge, and that is what do we do with Mycoplasma pneumonia, which is not covered by amoxicillin and ampicillin, but is still a really frequent cause of pneumonia and has come back and has reemerged. So Mycoplasma is a frequent colonizer in up to 20% of children. So this is really important to understand that just because we detect Mycoplasma through PCR, which is highly sensitive and highly specific, that doesn't necessarily mean that they actually have an infection. It could just be that they're colonized with it. About 20% or more of children greater than 5 will have Mycoplasma, but most kids with Mycoplasma will recover without antibiotics if we miss those kids. And we actually think that percentage is much, much higher. And I will show you some randomized controlled trials in the next slide. So some clinical syndrome includes low-grade fever and usually a longer duration of fever. So we're thinking more the 5 to 7 days of low-grade fever, cough, malaise, headache, fatigue. Diffuse abnormal breath sounds are more common on physical exam, but again, that physical exam finding is not very reliable. And again, we have a high rate of improvement without targeted therapy. So macrolides can be prescribed to treat Mycoplasma, but as these next studies will show, they might not be needed. So Effectiveness of macrolides in pneumonia is unclear. So for atypical pneumonia, a Cochrane review concluded that there's insufficient evidence to draw any specific conclusions about the effectiveness of antibiotics for this condition in children. And so what you see are these are the most cited randomized control trials, but there's many, many, many really well done prospective and retrospective cohort studies that have shown the same thing, which is to say that most of these studies show that there's absolutely no difference in outcomes in kids who were treated or not treated with macrolides. And so what do we do? So the first thing we did again is to try to get an understanding of what was happening with macrolide. So in the top graph A here, you see that on the x-axis is the percent of people who actually got tested for mycoplasma versus the percent of people who actually got macrolide therapy. And there's no correlation. So people were prescribing macrolides, azithromycin empirically and not necessarily testing the kid. So one, there were probably a good number of kids who didn't actually have mycoplasma that were treated. And there were probably a good number of kids who did have mycoplasma that were left untreated because we're just not testing. The second thing is over the years before the pandemic, we see no change in mycoplasma testing, but a slight decrease in macrolide therapy until the pandemic. And so this graph to the right was published in MMWR by Maureen Diaz. And what they found is that the dark blue bars are all pneumonia, and then the light blue on top of that is mycoplasma pneumonia associated CAP. And whereas before the pandemic, we do again see some prevalence around that 20%, and then we see nothing for the first part of the pandemic. And then right after the first 2 years of the pandemic, again, very, very small amount. And then look here in 2024, there's this huge increase of mycoplasma pneumonia causing pneumonia. And then the black line is the percent of those with pneumonia infection. So again, we had sort of what I would say a normal percent. There was one peak at 30%. We know that mycoplasma circulates every 3 to 5 years. It will come back and have an outbreak and then it goes away. But what we're seeing is our sort of normal cycle didn't happen. And now we have this huge, huge proportion where it's up to like 55% of kids were getting mycoplasma pneumonia. And what's interesting is, again, before the pandemic, or 2018 to 2023, 95% were receiving macrolides. In 2024, 96% receiving macrolides, even though we don't have good studies to show that macrolides actually work in kids with mycoplasma pneumonia, which is commonly referred to as walking pneumonia. So why does this matter? Let's just give azithromycin to everyone. It's a 5-day Z-Pak. It's so easy. Well, we're going to increase resistance, and that's what people have seen. And so this is just, how does antibiotic resistance happen? And I don't know that we know exactly how it happens. There's a lot of different theories, but this is one of them. We use some sort of antibiotic. The drug-resistant bacteria are now allowed to grow and take over, and then some bacteria give their drug resistance to other bacteria, causing more problems. So on the left here, we see the rate of azithromycin prescribing in children. And what you can see is there's some states that in some areas, I would say, that prescribe more azithromycin than others. So darker purple indicates more azithromycin prescribing. And then what you can see is that equates to antibiotic resistance on the right. So in 2019, Ken Waits did a study where he looked at antibiotic resistance across different sites. And what is pretty clear is that in the southeast of the country, about 20% of kids had macrolide resistance mycoplasma, and that matches to the high rates of azithromycin prescribing. In the West Coast, right, when we're looking sort of the Northwest, the Pacific Northwest, or down in the southern part of California, right, our resistance levels are much lower, around 2%. And that again correlates with the fact that there's fewer azithromycin prescribing happening in those states. And I would say from most of our studies, the data doesn't show that prescribing with azithromycin versus not changes outcomes in children. So what does this mean? So why do I care so much? I care so much, and why this is a sort of not a new focus, but like I said, we've kind of done well with neurospectrum antibiotics. We're now moving on to this particular bacteria, is that there's a high level of resistance in other parts of the country, other parts of the world. So even though we have low resistance in the US, which is great, we have seen this slight increase of resistance over time. But what we're worried about is this really high level of resistance that we see in places like China, South Korea, and Japan, where up to 97% of all kids with pneumonia, I'm sorry, 97% of all kids with mycoplasma pneumonia have some sort of macrolide resistance. And even though even though mycoplasma pneumonia is usually very benign, usually very mild, again, it's called walking pneumonia. Most people can do well being treated as an outpatient. A lot of kids don't get admitted. Macrolide resistance mycoplasma tends to have more side effects and have more severity to it. So kids with macrolide resistant mycoplasma are more likely to be admitted to the hospital, more likely to get intensive care, more likely to have sort of extrapulmonary manifestations, things like Lyme, that we just don't see in kids with mycoplasma pneumonia very often. So it is a concern that if we don't sort of rein in our prescribing, we're going to end up with a high level of macrolide resistant mycoplasma pneumonia and actually make things a lot worse for children than we are right now. So what are we doing? So we continuously update our clinical pathways. And so this is a pathway that was created by the European Society for Pediatric Infectious Diseases that we are in preparation of publishing. That organization has approved it. We just need to go through the publishing process. But again, here what you'll see is we haven't really changed a lot of the narrow spectrum antibiotics, but what our big change was is if you suspect atypical, do not treat with macrolides. There are some very specific scenarios in which we think macrolides might help. So there have been some studies in kids who have asthma and mycoplasma in which macrolides might be helpful. And we think the reason is more to the anti-inflammatory properties of macrolides versus the antimicrobial properties of macrolides. So again, updating the pathways, this will be a global pathway because it does take in information from all parts of the world. And we took into account sort of global guidelines, so guidelines from the UK, the British Thoracic Society, as well as the US guidelines, as well as Canada, as well as we have some from Thailand and some other countries, and then looked at all the literature around pneumonia in all different countries and all different settings. And this is a very basic description of what we think a good clinical pathway could be. Again, there's always sort of caveats to everything, and so reading the actual guideline will be helpful. So my last slide is just some conclusions and next steps. So global epidemiology of CAP suggests that viruses are the most detected pathogens, even in very severe cases. One thing I will say is there's a large study that's being led by Todd Florin that's funded through PCORI that's looking at a watchful watching approach. So in kids that are managed in the outpatient setting, instead of prescribing antibiotics, if there's a way to, sort of like what we do with otitis media, is not prescribing antibiotics and say, let's wait to see if it resolves on its own. It was a lot harder to ask providers not to prescribe antibiotics. So we started with, let's just try to prescribe narrow spectrum antibiotics. And now I think we're going to the harder task of, okay, now we're going to ask you not to prescribe antibiotics and or for viral pneumonia or for atypical pneumonia. We need to continue to improve diagnostic tests that differentiate viruses from bacteria. Some of the work that I do is more on the omics side. So I've used metabolomics, proteomics, and right now my study group is using metagenomic next generation sequencing to see if there's some better diagnostic tests, if we can actually look at sort of this host gene expression interaction with the microbe gene expression to see if we can identify kids who are more likely to have a viral versus a bacterial cause to their pneumonia, because that is really important, especially in very severe kids. We don't want to undertreat kids who are, in the PICU, but we definitely want to not overtreat most cases of pneumonia that are going to be mild or even moderate and, end up in admission, but possibly due to supportive care like oxygen therapy, not because they have a bacterial pneumonia. Like I said, empiric antibiotic prescribing may lead to increased levels of antibiotic-resistant organisms, which may lead to more severe disease, and macrolide-resistant mycoplasma pneumonia is a great example of this. So currently there's a randomized controlled trial that I'm a consultant on that's occurring in Switzerland called Mythic. where they're randomizing macrolide therapy for children with mycoplasma, with important clinical and patient outcomes. And we're also proposing to the NIH to do a similar study here in the US. So more to come. So when people have worked in their career for a long time, as I'm sure all of you know, there's a lot of individual people to thank. So instead of thanking all the individuals, because that would be many, many slides, I would like to just thank the sections that I work with and the people in those sections. So the section of emergency medicine and hospital medicine at Children's Hospital Colorado, the School of Public Health at Colorado. I also worked with the Division of Emergency Medicine, Biostatistics and Epi, and Hospital Medicine when I was at Cincinnati Children's Hospital. And then all of my collaborators everywhere in the US or globally, and all my funding sources. Thank you.
That's wonderful. Thank you, Lilliam. That's a lot of work, and it at times can be a very tough discussion and arena, I'm sure. And that's kind of my. I guess I'll start off with a question: how I mean, working in any one of these clinical scenarios would be tough, but how you choose educational interventions or how to approach really the competing demands and the different priorities for like the ER, the hospital, and the outpatient. There's different things that influence how you make decisions about patients in all of those different scenarios, especially in the world of pediatrics. What have you learned about how to educate in those different arenas and what factors you have to consider?
That's a great question. And I think the first part is understanding what's important to providers and families in those different settings. So when I went to community practices, I didn't start by saying, hey, this is what we're going to do. I started with what's an important, hear what the guidelines say, what's important to you or your families. And one thing that I heard a lot from my primary care pediatricians, as well as from our ER physicians, is we don't want families to feel like we are not providing evidence-based care because we're not giving antibiotics or because we're giving narrow spectrum antibiotics when they're expecting something else. And so how do we have that conversation? So some of that education wasn't even about what quote unquote you should be prescribing based on the guideline, but it was about how do we have these conversations with families so that they understand we are actually practicing evidence-based medicine. And this, I didn't show this as part of my talk today, but something we're doing right now is, again, encouraging people not to prescribe macrolides for kids with mycoplasma pneumonia. And I've had to have the conversation with community care or primary care providers and ER physicians and our hospitalists. Please don't question what the other provider did before you saw that patient. Please don't say in the ER, oh, your primary care provider should have given you a macrolide, because that's not true. So some of it is just making sure we have each other's backs. Well, I'm not a provider, but the providers have each other's backs and are giving the same message across the different settings. And then some of it is also just making sure that we're answering and showing the outcomes that are really important for those settings, which are different.
Yeah, it's clearly working. You're on your one map. Colorado was like the lightest color, so it stood out a lot. So it's obviously making an impact.
I don't think I can take any. That's not me, but I'll take credit.
Richard, can I ask a question, given
Sure.
I don't type? Thanks, Lilliam, for a wonderful presentation. My question is, well, I was thinking when you first showed the global epidemiology, and then you ended with the European guidelines. How will where will those guidelines be used? Are they going to be applicable in areas with some of the highest burden in sub-Saharan Africa, where, of course, the resistance is different, and also access is different? I was going through the flow chart and the slide, and I'm like, okay, how many of this is access related versus, and when you take both access and resistance into account, how much of this will the guideline will be applicable, or the new guideline will be applicable in areas with greatest need?
Yeah, that's a great question. And I would say this is where I'm going to reach out to you, Sam, and get your sage wisdom on how to do this. So the collaborators on the European Society for Pediatric Infectious Disease included 2 people from Italy, 1 person from Switzerland, 1 from Sweden, 1 from the UK, and 1 from Spain. So it is very European centric. A lot of those individuals do work in other settings in sub-Saharan Africa. And so some of what we were discussing is that idea of like, how do we spread these guidelines and how do we modify them to be applicable in those settings? Some of the access questions, I think, they're really tough. There's when I many years ago when I traveled to Tanzania, I remember somebody telling me like, you only go to the hospital to die. You only go to the hospital if you're like past the point of being helped. Obviously, that's too late for most, not most cases of pneumonia, but that could be too late for pneumonia. And so trying to get amoxicillin, which is very cheap, out to sort of villages sooner, or even just trying to increase the vaccination campaign in those areas, that's really what's going to help. So if we, and that work is being done, but to your point, I think it's meeting people where they're at and saying, okay, here's our guideline. Is this going to work in your context? And that's true of the US too. Like there was the national guidelines, but then we had to say, well, our local guideline at Cincinnati said cephalosporins. Well, that's clearly not with the national guideline. So let's meet, let's discuss, let's figure out where the buy-in is and how we can do this.
Thank you. And just a follow-up question, and
Mhm.
from an implementation science perspective, I guess when you put out these guidelines, how much opportunities are there for adapting it to the local context in a way? So whenever a major society puts out a guideline, it's almost like we seem to follow it, or at least try to follow it. I was just thinking about the whole U.S. Preventative Task Force pipeline of,
Yeah.
and so what do you think, from your previous experience of this guideline, how much of this has been just tried to implement it as it is versus modifications? Any such data out there?
It's a good question. I don't know if there's any data of people just trying to implement as is. I think it always has to be modified a little bit to your local context. But I do think that's the hardest part of implementation science and why that's a whole field, right? Is that we can say you should do whatever we say, and that's not going to work. And so when we do passive implementation, meaning like the guideline comes out and then we wait for people to adopt it, some studies have said that takes up to 17 years. That's too long. In 17 years, we've already learned enough things that those guidelines should be changing. And so there has to be more active sort of engagement and interaction with those guidelines. And so some of it is presenting at academic societies, as cheesy as that sounds, and making sure you're disseminating that information and talking to people across sites. But some of it is, and I think the harder part is going to community hospitals, at least in the US, or going to primary care and saying, hey, this is what, the guideline says, is this going to work for what you do? And I just think you have to be very cognizant of doing that work because it's so easy for us just to do the work. And I'm speaking as somebody who works in a hospital in an academic institution. Like it's so easy for us to just do the work at an academic institution and not actually reach beyond our borders and say like, actually, we need, and again, I do pneumonia. So pneumonia is much more impactful in the outpatient setting than what we see in the patient. So.
Thank you.
Yeah.
Great. I don't see any questions in the chat. Does anyone have any questions for Lilliam or about the presentation or anything else?
I'll throw in another question here,
Sam and I are just going to have a conversation. It's just going to happen.
You started a presentation saying about quality improvement science, right? And it always comes to me, what is quality improvement? It's a very basic question and I should probably know it, but what is quality improvement science and how is it different from the QI methodology we use in general?
Yeah, so it is similar. So quality improvement and QI are, they're the same science. And I think implementation science is, I learned about quality improvement before I learned about implementation science. And so to me, when I was learning about implementation science, I was like, oh, there's so much overlap here about what we do with quality improvement. And so I don't know that they're different in the theory. They're not necessarily different in the execution. I think that implementation science has many more frameworks than quality improvement science does. But at the end of the day, it's all about changing human behavior in a very complex system. And then where quality improvement, I think, are small, fast changes that we implement right away to see if they work. Implementation science is a little bit more of a, I don't want to say thoughtful because that makes QI sound not thoughtful, but it is a little bit more of a thoughtful, like understanding the context, doing more longer qualitative type research. But I think they work hand in hand. I think knowing both is very, very helpful. And there's a great scientist at Nationwide Children's in Ohio, Amy Taylor, who gives a really great talk, or used to give a really great talk at PAS every year, about how do we do both? How do we do QI and sort of marry that to implementation science to get the best results? So, yeah.
Thank you.
Anyone else? Any other thoughts?
Out of curiosity, are most of the attendings adult physicians?
I think I see many pediatricians, but many
Oh,
adults as
good.
well. A little bit of both.
Excellent.
A little bit of both. I mean, I'm trying to think. When you said about the point about community acquired or mycoplasma, you're taught that's wheezing. If a kid has wheezing, that's what they have. I absolutely remember being taught that, which in retrospect is kind of silly, but that's you learn those things when you're 24 and you just take it as gospel.
Yep. And so there's a lot of sort of unteaching of that and saying that's actually not true, which I think is hard. And I do think it's a lot harder not to do something than to do something. So
Right.
the de-implementation is hard.
Yeah. Well, thank you. I think it was wonderful. I learned a ton for sure.
Thanks.
And I loved all the Cincinnati connections. It's nice hearing Todd and some of those other names. That's great.
Yeah.
Yeah.
Ohio's a good place, guys. You guys live in a good place. I like it.
Yeah.
Yeah.
Cool. Good.
Well, thanks so much again for the invitation. And if any questions do arise after, please feel free to email me. I'm always happy to have these conversations.
Perfect. Thank you very much, Lilliam. Very good to see you.
Thanks.
You too.
Bye.
Bye, everyone.